All right. Well, thank you for the introduction, Pat. So as Pat said, I'm a behavioral neurologist, and I practice here in North Carolina. I'm from North Carolina and did train with Dan Coffer in residency. He was a great friend and mentor. And so Pat had asked me to talk about treatments in Lewy body dementia and frontotemporal dementia today. So I'm going to do my best to kind of walk through my thought process when I'm taking care of individuals who have either of these diagnoses. I'm also going to spend a little bit of time before just jumping right into treatments, going over some language, defining some things so that we're all working from kind of the same playbook. Um, and this will not take the whole hour and a half, so I will definitely have time for questions. Talking about treatments, of course, I can't give any specific medical advice, but I can at least provide sort of a broad overview of how I think about particular situations. As I am a part-time federal employee, just a note that none of my views are those of the federal government. So we're going to talk about some common language for both what is MCI, what is dementia, and then what are Lewy body dementias and the frontotemporal dementias. And we're just going to talk about treatments for both of those. The things that I tend to go to, what the data suggests we're able to treat and what we're less able to treat. So first, just to kind of go over a model, and I draw this for essentially every patient that comes through clinic because I think it helps to put in perspective what we're talking about with mild cognitive impairment and dementia. So normal aging, we all have changes as we age, right? Our skin changes, our hair changes, our muscles change, and our brains change. And that includes some normal expected cognitive changes. Not uncommon for folks to have some mild word finding difficulties and difficulty with sort of executive functions, and multitasking is a little harder, maybe slower processing speed. And folks come to me with the question of, is what I'm experiencing normal aging or more than normal aging? So mild cognitive impairment means that when somebody's concerned about that, we can measure that there is in fact a decline from where we would expect their cognitive abilities to be for a given age, education level, and the like. But importantly, at the mild cognitive impairment stage, there really are not major declines in daily activities, things like driving, shopping, paying bills. Now, there can be a little bit of a reduction in how efficient you are, or maybe need a little support, but you're still kind of able to get by with those. Mild cognitive impairment, importantly, is not a precise diagnosis. Frankly, neither is dementia. It's a description. And at the mild cognitive impairment stage, some individuals I see actually get better. These are folks that maybe came in and they've had untreated sleep problems and depression and chronic pain, and those things get under control and we see improvement. Some individuals have stability over a number of years and don't really get worse, but in probably half, that number can vary a bit, but around half, mild cognitive impairment represents a pre-dementia stage. So anybody with Alzheimer's disease or Lewy body dementia or frontotemporal dementia, these progressive conditions will have gone through an MCI stage. Now, because they weren't having problems, sometimes it doesn't really come to attention because you gotta measure it to see that decline, and it may not impact people's day-to-day lives. But theoretically, everyone who has one of these degenerative dementias will have gone through these more subtle changes first. Dementia means that we can both measure those impairments on scores of cognitive abilities, but it also impacts daily life: driving, shopping, cooking, cleaning, paying bills, managing medications. When those things are impacted, that's what we would refer to as mild dementia. If the basic daily activities, things, physical needs, dressing and personal hygiene are impacted. That's what we would refer to as moderate dementia. And finally, if somebody's fully dependent on someone else for their care, then that would be called severe dementia. Now, dementia is a term that describes that syndrome of cognitive impairment with functional impairment, but dementia has to be caused by a more specific disease. Sometimes we're able to discern what that is, other times it's more difficult. You can see here Alzheimer's and vascular disease are probably the two most common things that we see, but behind Alzheimer's disease, Lewy body dementia is the second most common degenerative cause of dementia, and then frontotemporal dementia is a bit more rare than that, but it probably makes up around 10 to 15% of individuals living with dementia. So Lewy body, the terminology for Lewy body disease is really a bit complicated, and you will see even other physicians not use this precisely. And so I'm going to show you what's sort of the ground truth, but then I'm going to also tell you how most people use the term. So Lewy body disease is a category that makes up both Parkinson's disease and Lewy body dementia. And that just means that if we look in the brains of individuals with both of these diseases, we see these things called Lewy bodies. Now, Lewy body dementia is technically not the precise diagnosis. Lewy body dementia is either Parkinson's disease dementia or dementia with Lewy bodies. And believe me, I know how complicated that is to have Lewy body dementia and dementia with Lewy bodies. Just flip the words around and they mean slightly different things. It's really complicated for my residents and trainees when I'm trying to teach them this. The difference is when or if the motor manifestations of the disease are present. If somebody has well-established Parkinson's disease, then you could call that Lewy body dementia, but you might more precisely refer to that as Parkinson's disease dementia. Conversely, if somebody had the onset of these the cognitive changes and then the Parkinsonism developed 6 months later or maybe a year later, then we could call that Lewy body dementia, and we would be correct, but we might more precisely refer to that as dementia with Lewy bodies to indicate that the cognitive changes began first. Now, most providers that I've seen outside of those who are really kind of deep into this area will just use the term Lewy body dementia to kind of refer to dementia with Lewy bodies. And so it gets a little complicated. People will say, oh, is that LBD, or do they have Parkinson's disease dementia? And that question doesn't really make any sense because Parkinson's disease dementia is Lewy body dementia. But the reason I bring this up is that you're gonna, if you are caring for or living with Lewy body dementia or dementia with Lewy bodies, you're gonna see these terms used in a very messy way. And so just know that that's kind of the rule rather than the exception. Now, Robin Williams and Susan Snyder Williams have done quite a bit of advocacy work trying to raise awareness about Lewy body dementia. She's written a nice editorial in one of our neurology magazines to kind of describe what people were living with, what Robin was living with, and at autopsy he was found to have Lewy body dementia, in this case dementia with Lewy bodies. And she really described what a lot of patients have told me. You know, somebody who was very lucid and then 5 minutes later just incredibly lost in confusion, blank. And would talk about wanting to reboot his brain. And I've had a lot of patients tell me similar things to that. So now I'm going to describe frontotemporal dementia, and then we're going to talk about treatments for Lewy body dementia, and then treatments for frontotemporal dementia. So again, the terminology here can be a little confusing. Frontotemporal dementia is often used to refer to a specific variant. When people say FTD, they often mean the behavioral variant of frontotemporal dementia. But there are two language variants. There are two language variants of frontotemporal dementia. The behavioral variant has early loss of sympathy, empathy, apathy, craving carbs and sweets, ritualistic behaviors, behaving socially inappropriately. And this can be a very tough diagnosis. And we know that if somebody is diagnosed with behavioral variant FTD, of all the dementias 3 years later, that's the one most likely to be revised. And that's because these are, what counts as craving carbs, right? So is eating a whole bag of potato chips carb craving, or is it eating 5 boxes of Pop-Tarts? And so you can see they're both craving carbs, but it's easy to fit both of those into this diagnostic category. And it can, I've had to revise this diagnosis more than others. And that can be really, really tough, especially when people are given a really high probability, when they're told, nope, this is what this is. And maybe the imaging didn't quite support it. And so 5 years in, we may have to say, well, actually, this looks more like Alzheimer's disease. And so behavioral variant FTD can be a little bit of a tricky diagnosis. It's also conversely missed the other direction. So it's not uncommon for individuals to receive psychiatric diagnoses like bipolar disorder, depression, or schizophrenia before being correctly diagnosed with frontotemporal dementia. Now, there's also two language variants of frontotemporal dementia that each look a little bit different than the other, but they both feature prominently with early language changes. So now I'm going to step into talking about treatments for Lewy body dementia. And there are some subtleties in the differences between Parkinson's disease dementia and dementia with Lewy bodies, but essentially the approach is similar. The focus might be a little bit different, and I'll try to point out where that is. So the first thing that I really try to have as a primary principle here, so starting, a question that's often asked early on is, so what are we going to do about this disease? And one of the tough conversations that I always have in that first visit is that I don't have treatments that will treat the underlying disease. I can't affect the ultimate progression of this disease with any modifying therapy. We just don't have that yet. We hope to one day, but right now we don't. And so what I can do is treat symptoms. I can help alleviate suffering and distress, and talk to the caregivers and patients about what symptoms are bothering them and worsening their life the most. And sometimes it's a symptom I can treat. Sometimes it's a symptom I can't treat. And I try to be really upfront when there are things that may come up that I don't think I'm going to make better. And I always try to have an ongoing conversation with caregivers and patients about what's bothering them most. And each person is unique. The way that I approach any individual patient, and this is true across dementias, there's not sort of a, we have to do this first and this second and this third. It's more of trying to understand where each person is, because if I'm treating symptoms and trying to make someone's life better, and each of those things are different, then it makes sense that not every person's gonna require the same approach and treatment. So I'm gonna go through each of the categories that I am able to treat, what I am able to do, and talk a bit about that. a lot of this comes from this really great program at Newcastle University. And so anybody who's familiar with a lot of the science of Lewy body dementia might recognize Newcastle as where Ian McKeith is, who is easily one of the most famous names in the LBD world. He is the lead author on essentially every diagnostic criteria that's ever been put out for dementia with Lewy bodies. And they have a really great website with assessment toolkits and management toolkits that can be useful for clinicians. And so people who may be less familiar with Lewy body dementias, this may provide a bit of guidance. And it includes things like this sort of management card of an overview. And we'll talk, and it sort of gives some general advice on everything, cognitive, neuropsychiatric, sleep, motor, and autonomic. But then for each of these categories, you've got these management summary sheets for each category. And so for the cognitive symptoms, you see they blow it up much larger so that it goes through each of the things that are present. So general principles for the providers and clinicians. Also, what do cholinesterase inhibitors do for you? What are the side effects, the adverse effects, etc. So these are really comprehensive and can be helpful for clinicians who may not have as much experience with Lewy body dementia. Now, I will say I don't agree with everything on here, and that's not uncommon. I have slightly different takes, and so some of the things that I'm going to tell you won't parrot this exactly, but these are really, really good resources. So I'm going to take a step back, and now I'm just going to go over cognitive symptoms. So for Lewy body dementias, cholinesterase inhibitors are really the mainstay of management. They are the most important things that I've seen that I'm able to get people on. And these are not FDA approved for Lewy body dementia. One of them, rivastigmine, is FDA approved for Parkinson's disease dementia. But the data really suggests that they all kind of work the same. It doesn't matter whether it's donepezil or whether it is rivastigmine or galantamine. And they seem to both help. They may help stabilize the fluctuations in Lewy body dementia. They can treat the psychosis, so the hallucinations or even the delusions, which can be much more difficult to treat. And they can help with the cognition by helping some of those fluctuations, helping improve alertness and arousal. This is the only diagnosis where I will sometimes go above the maximum recommended dose. So donepezil or Aricept, the maximum dose is 10 milligrams daily, usually given in the morning. I have at times gone above that dose. That is, that's something that I would imagine not every neurologist will do. There's less evidence for that, but certainly some people in the behavioral neurology community, especially those at some of my colleagues at Mayo, where Brad Beauvais is, who's another big name in Lewy body dementia, will push the cholinesterase inhibitors a bit higher. The challenge is that the side effects are often worse, right? And so, especially the stomach upset with nausea and diarrhea. The main side effect I really worry about is that it can slow people's heart rate down, and it can induce a heart block, can make them, so their heart rate might drop from 60 to 40, and they could feel very dizzy, feel like they're going to pass out. I've even rarely had people lose consciousness and briefly pass out. And so sometimes we need an EKG first. If people are bothered by the stomach upset and it doesn't get better, the options are to go really slowly with the pills. So instead of 5 milligrams and then 10 milligrams after a month, we might do 2.5, 5, 7.5, and 10. The patch of rivastigmine, the Exelon patch, can reduce the stomach upset, but it can be real tough with insurance. Sometimes they won't approve it. Sometimes they will, and it's almost impossible for me to know whether they will or won't approve it. The other medicine for cognitive symptoms has less data, but this is Namenda or memantine. It is it's approved for Alzheimer's disease. It's usually quite well tolerated. We go up to a maximum dose of 20 milligrams, usually given 10 milligrams twice a day. Can also cause some stomach upset, so I would never start this at the same time as a cholinesterase inhibitor. And occasionally it can cause some difficulty with sleepiness or dizziness, or even I've had some patients who seemed more confused. So any drug that I start, I tell families to just let me know what they see, because I'm not going to argue. If we start something and your day-to-day life is worse, we may need to stop that drug. And I'm always willing to listen to what someone's day-to-day experience is with those drugs. So those are really your only two so-called cognitive medications that are used in Lewy body dementia. A much larger category of symptoms to treat with Lewy body dementias are the neuropsychiatric symptoms, sometimes also called behavioral and psychological symptoms of dementia. These are kind of the emotional and behavioral symptoms that do occur related to dementia. The first question is always, well, do we need to treat them? And sometimes the answer is no. So if somebody has infrequent, not harmful hallucinations, for instance, that are easily redirected, they doesn't bother them too much and doesn't cause them distress, we may not need to treat those right now. And the reason to consider that is that every medicine has side effects. And every medicine can both help, but it can also hurt. And so if we don't need to treat, the right thing to do may be to talk about it, discuss it, and then keep an eye on it. And for some things, medications may not be very effective. So as an example of that, if somebody comes in and they have verbal aggression, well, some things are responsive and other things are not, that could all lead to that verbal aggression. And so if somebody's in pain and that's making them aggressive, if somebody has psychosis or depression, we may be able to treat that. But other things, I can't treat a sense of powerlessness and boredom, or, if they're in a nursing home and they don't feel that their care needs are being met, or they've just lost, they've lost the power to control their own lives. If that's what's leading to the aggression, that's much harder to treat, and trying to find environmental changes may work better. The first thing is always to consider safety, though, right? So is someone a danger to themselves or others, and does that thing need to be treated much more rapidly? Physical causes are really important to consider prior to adding a medication, especially when things come out all of a sudden, right? It's one thing if someone's had some hallucinations for months and they're just getting a bit worse. It's a very different situation if somebody's never had them and they all of a sudden come on, because that could be caused by an underlying infection, sensory problems, poor sleep, or even pain and discomfort, things like severe constipation. And those may need to be treated. And then medications are a big potential source of worsening both behaviors and confusion in Lewy body dementia, especially, but in all dementias. And so the medicines, we could go through a bunch of different categories. What I wanted to do instead is just put up one slide that sort of has the what I would consider the worst offenders in my experience. And so the over-the-counter sleep meds are really, really bad for anyone who has cognitive impairment. And so those are things, Benadryl, NyQuil, anything with PM behind it, so Tylenol PM. And the reason is those medicines that make you sleepy are anticholinergic medicines. And so without going into the neuropharmacology of it, the cholinesterase inhibitors that I've told you help these symptoms, well, they increase the amount of acetylcholine. The anticholinergics decrease the amount. So it makes sense that if one's helping things, the one that does the exact opposite can make these symptoms worse. And so those sleep medicines are usually not a great option. If I have to use a medicine for sleep, I may try melatonin first. If that's not enough, trazodone is a prescription medicine that usually works a bit better with less of a hangover effect than those over-the-counter medicines. For allergies, Claritin is a better option than Benadryl, for instance. Benzodiazepines can be a bad medicine for folks to be on. Sometimes it's needed, and so there's exceptions to every rule. But if folks are on benzodiazepines and it's causing some worsening confusion or sedation, we may have to very slowly try to come off of that medicine and use other things like buspirone if necessary. And sometimes the benzodiazepines really aren't needed any longer, and you can safely get off of them. But it's tough, and it's sort of a slow transition if that's necessary. Oxybutynin, which is a very common medicine for incontinence and bladder problems, is anticholinergic, just like the ones up top, and so may have to talk to someone's primary doc about switching to Myrbetriq or one of the newer drugs. Meclizine and dimenhydrinate or Antivert are used over the counter to treat vertigo, but can also worsen confusion. And so maybe doing vestibular rehab could help. If people are on antidepressants, the older ones like amitriptyline and Paxil in particular is a pretty bad offender because it's, again, anticholinergic. Muscle relaxers can cause worsening confusion, as can the antispasmodic agents for stomach cramps. So dicyclamine is a fairly common one. And anything that we can do if these were recently started and these symptoms popped up, it might be a particular argument for trying to come off of them. If that's not the case, if it's not caused by a physical symptom, delirium, or a medication, when we talk about what can we treat with different classes of medicines? So antidepressants are kind of a bad name because we use it for more than just depression. There's nothing inherently specific about the drug to make it an antidepressant. From my perspective, it affects particular chemicals and receptors and circuits in the brain that may help with depression, but calling it an antidepressant is really a marketing tool, not a pharmacological one. And so these are things like your selective serotonin reuptake inhibitors or related medicines like venlafaxine and bupropion, and they can be used for agitation. Agitation just referring to sort of irritability, increased motor activity, pacing, fidgeting, etc. Depression, they are of course used for. Anxiety, they can be effective for. Usually the ones up top, more like the Zoloft or the Celexa. And then for apathy, the ones that affect norepinephrine as well, like the Effexors or Wellbutrins, can help improve apathy in some folks. The antipsychotic drugs, again, antipsychotic is sort of a bit of a marketing tool. They are used in primary disorders that cause psychosis, like schizophrenia. Now, in LBD, this is a really important class of drugs to be aware of because many of them can make things worse. And one of the experiences I have as a consultant is I will sometimes be called to see people who, went into the hospital, got delirious, they have Lewy body dementia, and then somebody gave them Haldol. And Haldol is an old antipsychotic that is really not a good idea in Lewy body dementia. And so I will have to sort of go in and get that medicine stopped and make the suggestion to use other things. Now, it's not uncommon for people to be incredibly delirious, confused, dangerous to themselves even in the hospital, and they may need a medication for safety, but it just cannot be Haldol. And so if we have to use antipsychotics in the outpatient setting, really Seroquel is the main one that we go to. That's quetiapine. And for Parkinson's disease, dementia, we can use Nuplazid or pimavanserin, but it's not covered unless I can call it Parkinson's disease dementia. And so that it seems quite silly because we know that the Lewy body dementias are kind of two sides of the same coin, but because this is a very expensive drug and it was initially tested only in those with Parkinson's disease psychosis, the insurance companies are very, very strict about who I can prescribe it for. So if I have somebody that I've diagnosed with dementia with Lewy bodies, they won't cover it. It's a modestly effective drug. I've not been blown away by its efficacy, so it's, I'd like to be able to try it in some individuals, but at least it's not being withheld, and it's a remarkably effective drug. Important to know for the antipsychotics, and something that I do talk to all of my patients about, is there is a black box warning for the use of antipsychotics in dementia. It very likely does increase the risk of cardiovascular and so heart attack and stroke related mortality. And I think it's true that it does increase the mortality rate. And so I don't want to use these drugs unless I have to. And the reason that we would have to is when the symptoms are just causing distress for the individual having them, when it makes it impossible to provide that care for someone. At that point, the conversation of, well, do we take this theoretical but real increase in risk and try to improve the symptoms, or do we not, in which case we've taken one of the only tools that I have to try to treat those symptoms off the table. And so it's a conversation that we always have, but I think it's an important one to have so that everybody knows that, the medications are not without risk, and that we're taking the risk in an appropriate palliative way, that we know we're trying to improve the quality of life. And if we don't meet that goal, then we need to stop the medicines that have that risk. And so psychosis is the most common thing we use these for, but also aggression, because these drugs are essentially, they have a tranquilizing effect. That was the first name for antipsychotics in the 60s, was major tranquilizers, because they do have a sedating effect. And then finally, if the agitation is really bad and less potent drugs have not worked, and then for really bad anxiety, sometimes it can be helpful, the low dose quetiapine. Now, cholinesterase inhibitors you saw under cognitive disorders, but you'll notice here that I've also put it under neuropsychiatric symptoms, because it turns out they also help with psychosis in Lewy body dementia. Importantly, though, you don't give these in frontotemporal dementia. Can help with depression along with an SSRI, and it can help with apathy, and is really my first line treatment for trying to improve apathy. So trazodone and mirtazapine, these are medicines. They're old antidepressants, and we don't use them for first line therapy for depression because they make people sleepy. But as a consequence, they're pretty good for insomnia. And melatonin in particular for REM behavior disorder, and sometimes for insomnia, we try that first because it's pretty benign and unlikely to have bad side effects. Now, memantine, again, mentioned under cognitive, but I'm putting here because there's some growing evidence that it can help with the severity of these symptoms. The way I think about memantine here is very similar to the way I think about Tylenol in chronic pain. So individuals who are using opiates for chronic pain, well, Tylenol is not going to fix the problem. Tylenol is not going to solve all the needs, but we do know it actually decreases the amount of opiates that you need for chronic pain. And so in the same way, sometimes getting folks on Namenda and a cholinesterase inhibitor may mean that I can use less antipsychotic, which is ultimately good because antipsychotics have the most risk associated with them. And because this is a well-tolerated medicine, it's usually worth a try. Now, benzodiazepines come with, I just told you they're a bad drug. And that's true, they are bad. And I don't like to use them, but there are exceptions for every rule. So really bad insomnia for very short-term use, and for REM behavior disorder, clonazepam is the most effective medicine. It's the most effective treatment. We try melatonin first because it's less harmful, but clonazepam ultimately may be what's necessary to treat the REM behavior disorder. Now, I've also had to use benzodiazepines in severe anxiety that might emerge later in the course of the dementia. And again, we have this conversation as kind of, it's a lot of what I do long-term is neuropsychiatric palliative care. We talk about what's most damaging to the day-to-day life of somebody. And if the answer to chronic debilitating anxiety is a low-dose Klonopin, well, then that may be what we end up doing, but cautiously and understanding that there are risks associated with it. Now, stimulants, things like methylphenidate or modafinil. So these, there's some controversy because they probably do increase the risk of cardiovascular events in the first 30 days of their use because they increase blood pressure, they're stimulating drugs. We know that when people have severe depression and they're very sort of melancholic and down and apathetic, giving a low dose of a stimulant along with the antidepressant can help improve the depression. We know that it's effective for the treatment of apathy, at least in Alzheimer's disease, and probably in Lewy body dementia as well. And finally, with Lewy body dementia, the severe daytime somnolence and fluctuations, the problems with wakefulness. I have patients that come in and their caregivers say, I mean, they're in bed 20 hours a day. They when they're up, they can do some for themselves, but their quality of life has just been decimated. They're so tired all the time that they can't do things. Well, that may be an appropriate time if we've ruled out, untreated sleep apnea and things like that. That may be an appropriate time that I would consider using stimulants. But again, it's not without risk. All medicines have these risks, and it's important to have a conversation with what are the risks and what are you hoping to get. And if you don't get what you're hoping for after a couple of months, you may have to come off of a medicine. Now, motor symptoms, this is one of the areas where Parkinson's disease dementia and dementia with Lewy bodies differ. In Parkinson's disease dementia, the motor symptoms are usually pretty severe. In dementia with Lewy bodies, the motor symptoms are often, but not always, less severe, and they're less likely to respond to dopamine replacement. Doesn't mean that it won't respond, but it's less likely to. Levodopa, or carbidopa levodopa, Sinemet is the brand name, is really the only medicine that I use for treatment of this, and that's because the others have troubling side effects, especially dopamine agonists can worsen psychosis, worsen impulse control problems, etc. And I've definitely had to slowly get those other medicines off and go up on the Sinemet to manage this. And you got to watch for worsening psychosis or developing psychosis, blood pressure dropping low, and being overly sedated. There's some new data that shows that maybe adding a seizure medication called zonisamide may help with the motor symptoms of Parkinson's disease. And so there was a phase 2 trial that showed this, and there's an ongoing phase 3 trial. It's a pretty well tolerated medicine, so myself and others will certainly try it. We use this all the time in headache medicine and for seizures. And so it's a low dose, 25 to 50 milligrams daily. And then physical therapy cannot be overstated, because physical therapy has very few side effects other than making you a bit sore and spending some of your time. But for gait problems and the like, physical therapy is probably more effective than anything I can do. Now, autonomic symptoms, these are a lot of really bothersome symptoms for people. And they're ones that are sometimes, if you don't understand the full picture of Lewy body disease, I've had people come in with what seems like this diverse array of unrelated symptoms, and it turns out it's actually all, related back to their dementia with Lewy bodies. They've got blurry vision that's from dry eyes. They've got new onset irritable bowel syndrome, which is probably an autonomic symptom in Lewy body dementia. They're passing out from their blood pressure dropping. Urinary retention is common. This may be a reason why somebody's put on oxybutylene, but it's not a great drug, so may need to look at a different medicine for that. Scheduling voiding can be helpful, a bit annoying to do, but just sort of setting a schedule to try to go to the bathroom every so often. Excessive sweating can be a problem. Sometimes if people are on dopamine medications, or if they're not on dopamine medications, occasionally the sweating will actually get better with Sinemet, or by increasing the Sinemet if it happens when their medicines wear off. Otherwise, this is mostly environmental management, making sure people are wearing cool clothes, making sure that the house is not too warm, etc. Excessive saliva, drooling can be a real problem for folks. Sometimes sugar-free chewing gum can help. Botox in the salivary glands is an option that our movement disorders folks do here. And then occasionally atropine drops. So these are eye drops, but they can be put in the mouth to reduce the production of saliva. Constipation is a huge problem, and one that should probably just be addressed at every visit, just to make sure it's not there. Certain medications worsen constipation, so opiates can cause worsening constipation. Using stool softeners or even mild suppositories. Miralax is a go-to, and so titrating that to the point that folks are having consistent bowel movements. Orthostatic hypotension, which means blood pressure dropping when you stand up. The first line are things that are called conservative measures. So having people stand more slowly, raising the head of the bed in the morning so that their blood pressure regulates before they stand up, eating more salt. It's one of the few times you'll hear your doctor say eat more salt, but this is one of them. Compression stockings and increasing fluid intake can help. If that doesn't help, if it's more severe than that, we do have medications like fludrocortisone or midodrine, which can help increase blood pressure, but it's a balancing act, because we don't want your blood pressure too low when you're standing up, but some of these medicines cause your blood pressure to spike high when you're lying flat. So I often have folks take their blood pressure both sitting and lying when we're starting these medications to make sure that their blood pressures aren't going up too high. Sleep is a real problem, commonly disordered in Lewy body dementias. The one that gets the most notice is the REM behavior disorder, because it's a core symptom. But sleep apnea is epidemic in healthcare. There's a lot of untreated cases of sleep apnea. A lot of folks that don't tolerate the masks very well. And I say this as somebody who has sleep apnea, so I get it. I know the mask. But if you have sleep apnea and it's not treated, I'm probably not going to make the other sleep problems very much better. And it's because sleep apnea can be such a important facet of improving insomnia. Even REM behavior disorder, if the sleep apnea is untreated, it can be a real problem. Excessive daytime somnolence goes hand in hand with this, because what happens in Lewy body dementia is the switch in your brainstem that sort of says sleep or be awake is where part of the problem is. And so people get these fluctuations, and it's like they're almost in a sleepy state. They can't wake up, they can't do things. And if your arousal is impaired, everything's impaired. You can't engage to do things. Treating sleep apnea can improve that daytime somnolence. If it's treated and if there's nothing else, this is where those stimulants may be appropriate, but really probably best prescribed by someone comfortable and familiar with their use in Lewy body disease. Restless leg syndrome can be part of LBD. One of the things that gets missed sometimes is checking ferritin levels and sort of an iron panel. Low iron can cause restless legs, and so sometimes I've made that better by just giving people iron replacement. Watching out for medicines like SSRIs. So I've had people that they come in and they've got bad restless legs, but they're taking their antidepressant at nighttime. Well, if you move that to the daytime, that may help the restless legs. And then finally, gabapentin is a pretty good go-to drug here. One of the main go-to drugs are the dopamine agonists, but we don't like to use those in Lewy body dementia because of the worsening psychosis that can happen there. So we try to avoid it. I do have patients who've come to me on those agonists. We've tried to take them away, and their sleep just gets terrible. It didn't seem to be worsening the psychosis. So, like I said, there's exceptions to every rule, and I'm not going to argue with someone's day-to-day experience of everything getting worse when we take them off of that dopamine agonist that's low dose and well tolerated. Insomnia. Sleep hygiene is important, but it's often not enough, and it's hard, right, to keep a regular sleep pattern, don't nap during the day, exercise regularly. Those are great pieces of advice, but they're sometimes just hard to implement and not enough. Try to review medications, make sure people are getting nocturia treated. So if they're peeing all the time at night, may need to work with their primary doc to treat that. Melatonin's a good start, and I usually start this at 3 milligrams nightly, an hour before bedtime. Other over-the-counter should really be avoided, and this is somewhere that I may use that trazodone or melatonin as a prescription if it becomes necessary. And then REM behavior disorder. This is the one, like I said, that gets all the attention in Lewy body dementia. And that's because it is part of the core diagnostic criteria. Now, it's not specific to Lewy body dementia. REM behavior disorder can occur in anything that causes an increase in the protein of alpha-synuclein. And so that includes Parkinson's disease, Lewy body dementia, and a related disorder called multiple system atrophy, which is not a Lewy body disease, but it is associated with REM behavior disorder. It's just the reason it's a core criteria is because if you come in with dementia and hallucinations and then you have REM behavior disorder, it is very highly suggestive of Lewy body dementia. Melatonin is the first go-to. It's well tolerated and safe. Clonazepam is the most effective, but it can increase risk of falls and worsen cognition. All right, so that was a sort of a whirlwind tour of treatments, management in Lewy body dementia. I'm going to move along to frontotemporal dementia. And so what I'm going to show you here is the difference between behavioral variant frontotemporal dementia and one of the language variants. So if you look at this, this is showing impairment here, and this is severity along here. So you'll see behaviors are really the very first thing that you see, and the cognitive changes occur later. And so as the first thing that is often seen in behavioral variant FTD are these difficulties with regulation, social decorum, problem solving, and judgment. Eventually, those things may lead to eating changes, poor personal care, and trouble in the community. And then you'll start to see the cognitive changes creep in as the disease progresses. So executive functions, language changes even, and then finally memory and spatial awareness. Now, compare that to this language variant. So the first thing that you see here is really it's isolated language for a while. And none of the medicines or treatments that I have, other than speech therapy, will treat the language problems. And so there's often a little less active management early on for me in the primary progressive aphasias, other than getting folks to a speech therapist who may be able to help. As those language disorders progress, there are eventually changes in behavior and other cognition that come in, and so then more active management is often necessary. Again, my treatment philosophy is to target what's causing the most problems. Sometimes I can't target the thing that's the biggest bother. Non-medication things that are important, making sure that we've talked about what to expect, what those symptoms are, where they're coming from, trying to figure out a way to get the person caring for that individual a regular sleep schedule. If for those of you in the audience who are caregivers, I don't have to tell you that your sleep schedule can be very hard to manage when you're taking care of somebody with dementia, but it's also so incredibly important because if your gas tank is empty, it's so much harder to do the hard and important work that you are doing for your loved one. Trying to find social workers that can help. This can be real tough depending on the health system. We're lucky at Wake that we have a memory counseling program that is staffed by therapists and social workers. And we're also very fortunate in North Carolina to have the Dementia Alliance of North Carolina, who have a helpline that they can sort of help people with figuring out community resources, where to go next. They may have grants that can help with respite and the like. And then thinking through things about, is it safe to be driving? One of the toughest conversations I have, regardless of the dementia, no one wants to hear that I don't think they should drive or that I think they should get tested before continuing to drive. And that's often where the most anger comes out when I talk about that. But I try to always tell family members that, my job, I'm paid for people to be able to be angry at me. So I don't want caregivers to be the ones having to say, no, you shouldn't drive. I want them to be able to use me and say, remember, Dr. Bateman said you shouldn't drive. That's my job, and I don't live with the person who's going to be angry about it. And so using me and the physician as much as possible to say, the doctor said you shouldn't do this. So cognition in frontotemporal dementias, really nothing has worked. The medicines just have not been effective. And so improving someone's memory in frontotemporal dementia is really not a good goal to have, because we're unlikely to do it in a consistent way. Cholinesterase inhibitors and memantine do not work. They've been pretty clearly shown not to work. And cholinesterase inhibitors, at least, can actually worsen behaviors in FTD. Now, where I mentioned earlier that the diagnosis of frontotemporal dementia is complicated, I've had more than one patient come to me who's been told, you have frontotemporal dementia, they're on a cholinesterase inhibitor, they're doing well, they don't want to stop the cholinesterase inhibitor, and on my evaluation, I don't think they have frontotemporal dementia. They probably had an Alzheimer's disease variant that just had a bit more behavioral changes early on. And so what I'm talking about here is in really well diagnosed, probable frontotemporal dementia. In sort of the messiness of clinical work, of course, I see people who come in with a label of frontotemporal dementia who these medicines may have worked for. But keeping in mind that in any frontotemporal dementia disease cohort, 25% of those individuals may have Alzheimer's disease underlying as the pathology. And that's because of these atypical variants of Alzheimer's disease that sometimes get mistaken. The best studies on frontotemporal dementia have looked at medicines that affect the levels of serotonin. And that's because there's pretty consistently degeneration of and deficits in that neurotransmitter. And so those were the first drugs that were tried. That was sort of the tip that we should try the drugs that affect these, the levels of these. So the antidepressants, the selective serotonin reuptake inhibitors, have been shown to help improve obsessions, repetitive behaviors, agitation, inhibition. And so those are kind of a mainstay in FTD. Trazodone can be useful and helpful and for intermittent agitation and sleep difficulties. And then antipsychotics occasionally are necessary, but we have to watch because frontotemporal dementia is also associated with Parkinsonism. Parkinsonism isn't unique to Parkinson's disease or Lewy body dementia. You can see it in frontotemporal dementia, and it does not mean there is a separate diagnosis. And so we have to watch which antipsychotics we use. As I said, they are occasionally needed. I tend to use quetiapine. I've used others, but that does tend to be the one I go to because of that. And then some of the anti-epileptic drugs like valproic acid and carbamazepine may help improve behavioral symptoms. They're not the first thing I go to. Topiramate, interestingly, has case reports of improving the hyperorality, which just means that some people with frontotemporal dementia will put just anything in their mouth and they'll eat nonstop, seemingly. And topiramate can actually help treat that potentially in some case reports. Physical, occupational, and speech therapy are probably some of the most important things that I get folks to, because it can help with decreasing falls, improving safety, and especially speech therapy for the language evaluations can be helpful. There's a very touching video that a colleague of mine has, I wish I had to share, somebody with one of the language variants of frontotemporal dementia you know, their daughter was getting married, and they desperately wanted to give a speech at their daughter's wedding. But you can imagine, with a language variant of a dementia, that was really daunting. But in this particular language variant, it turns out that you can overlearn to be able to say things. So frequent phrases you can overlearn. And he worked with a speech therapist to overlearn that speech that he wanted to give at his daughter's wedding, and was able to successfully give that. And just an incredibly touching thing that he was able to do to be a part of that special day. So that's all I have for you guys for the treatment. I'm happy to try to answer or take any questions here in the next little bit. I